Hi, everyone. Elizabeth and I are here, and we're going to get this show going for us today. We're going to split the screen and get Elizabeth starting. Hold on. There we go, Miss Elizabeth.
All right. Good morning, everybody. This is take 2. We are so sorry that, because I did a darn good job last week when we were doing this. I'm just hoping that today is just as good. And I hope everyone is doing well and staying healthy. And I know that many of you are working and are in the trenches, and I am just in such respect of the fact that you are. For me, in pediatric primary care, our census is so low and our appointment level is so low that I was the first one to get laid off. So I've been home a week now. I worked last Monday to lunch, and that was my last day. In fact, my last 2 patients were a parking lot visit because the mother of the 2 kids also has an elderly mother, and she did not want to enter the building. So I took everything out and went to her, and we did a parking lot visit. But I hope everyone is well and staying healthy. And so the first thing we're going to talk about today is ear disorders. Now, ears, and I may spend a lot of time on this today because ears are such an important part of what we see and do and deal with in pediatrics. So I'm pretty passionate about it. So when Dr. Blankenship and I last year were discussing about the different, I was like, oh, I got a lecture on ears because it's such an important part of what we do. So as we get started today, I want to also make sure that I reiterate to you the importance of reading chapter 30, which is the ear disorder chapter. It's a very good chapter. It is written by a friend of mine by the name of Ann Peterson Smith. I've worked with her on national policy statement committee for the National Association of Pediatric Nurse Practitioners. And she is an excellent educator, and she has done a phenomenal job with this chapter. So take time, spend time reading on this chapter, getting to know it. I'm going to go over a whole lot of it, but still, there's really good information in this chapter. So let's get started. So what do you always start with? You always start with anatomy, okay? So the ear, you've known the anatomy since you were in nursing school, and actually probably since you took anatomy and physiology, but we're going to talk a little bit about it just in relation to what I need you to remember. So you've got your outer ear, you've got your auricle or your pinna. That's what you're looking at. All right, and let's get this down because I get confused. So when I'm looking at this screen, I think patient right and left. So if you're looking at your screen, it is patient right and left. So your outer ear is on the right. So you'll hear me call that right, okay? So you've got your outer ear, and it is designed, or the auricle or the pinna, however you want to, and it's got different parts of it. And the ear is designed so it captures sound waves and brings it into the external auditory canal. So, and technically your external auditory canal, or the ear canal, has a proximal end and a distal end. Your proximal end is near the eardrum, and your distal end is at where it opens out to the air. Then you've got your tympanic membrane, and so much of PEDS deals with what's going on with that tympanic membrane. And then you've got the middle ear part. And our middle ear is comprised of the 3 bones, the malleus, the incus, the stapes. The malleus lays right next to the tympanic membrane, and the stapes rise right next to the oval window. So these 3 little bones, if there's damage to them, then we have permanent hearing loss, because they transmit the sound from the drum to the oval window to the semicircular canals, which stimulate the fluid and the hair follicles into the cochlea, and it's transferred, and we'll go over that in a minute. And I'm ahead of myself, which I did the other day. But the ear is just such a unique construction. You also see here the eustachian tube. And we're going to talk more about the eustachian tube and its purpose and how it configures into issues with ears in kids. So Now, the ear is important in that to know that embryonic development of the ear starts at the 3rd week of gestation and is completed by the 3rd month. Now, it's really interesting because kidneys and ears develop at the same time in gestation. So if you've got a kid with an ear anomaly, you need to really check the kidneys and make sure, assess kidney function. Now, if there's an ear anomaly at birth or an ultrasound before birth, a lot of times your neonatologist and your perinatalogist are going to have done further evaluation on that prior to birth of the child. And if you hear my phone go off, I have not put it on silent. I don't even know where my purse is. It's over there somewhere. So we'll deal with that later. So the other, as we talked about, the external auditory canal and its purpose, it transmits the sounds wave. The interesting part, it contains lots of stuff. It contains sweat and sebum and cerumen. And cerumen is earwax, and this helps lubricate the inside of the ear. It also helps move debris out of the ear, okay? And it is really important that we maintain an acidic pH in the external auditory canal. And I will talk about that more as we get to the conditions of the external auditory canal. We talked about the middle ear and what's going on there. The inner ear and its function is to transmit the sound and aid in balance. So you all probably already heard about Meniere's and anybody with vertigo, things like that, all have to do with a dysfunction in the inner ear. So that starts at that oval window of the cochlear nerve, and when sounds are transmitted through the ossicles to the oval, these vibrations stimulate the fluids and the organ of corti. It's just so exciting, all that goes on for you to be able to hear. Now, so when we get to the organ of corti and the hearing receptor hair cells are stimulated, what cranial nerve is being stimulated? Do 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 do. Do, 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 do. Don't make me tickle, Dr. Blankenship. Okay, so our little Jeopardy moment. If you haven't figured it out, it is the 8th cranial nerve. So on Old Olympus towering tops A, Finn and German viewed some hops. So the and between Finn and German. So that's your 8th cranial nerve, the auditory nerve. So it's really important. All right, moving to the eustachian tube function. I told you it was really important in what we do. We have 3 functions with respect to the middle ear. One is ventilation, okay? So the eustachian tube is really important in equalizing air pressure in the middle ear. With regards to atmospheric pressure and replaces oxygen that has been absorbed. Have any of you ever been on a plane when it's going up or descending and you had a little congestion and you felt like your ears were going to pop? Because so you had something going on in your eustachian tubes which prevented the stabilization of the atmospheric pressure. Or you had to swallow or chew gum or something so your ears would pop so you could get that cleared out. So another function of the eustachian tube is protection from nasopharyngeal sound. So put your hand over your ears, okay? We can hear ourselves, but now that you've got your hands over your ears, that sound is muffled. So if you didn't have the eustachian tube, you would just like be blowing yourself out of the water all the time. So it also protects from pressure and then other secretions. So, and then the 3rd function is drainage of secretions from the middle ear into the nasopharynx. So, and we're going to talk more about that and how that affects infection and other things as we go along. Oh, and by the way, I forgot to tell you, if you have any questions or would like to make an input on anything that we talk about today, we want to hear it. So send any questions to Dr. Blankenship and she will get them to me. And we also want comments. So something you've seen in your clinical time or personal experience as a parent. I've got significant experience with this as a parent before I went back, even though I was an RN, before I went back to become a an NP, which has really helped me a lot, understanding where parents are and what's going on, and to help them navigate through issues with the ears. So make a list, send them to Dr. Blankenship, and she'll get them to me, and then we will, I'll answer them, and we will get them back to everybody on Blackboard, right?
Yes,
Okay,
ma'am.
okay. Next slide. So let's talk about different things, that different diagnostic tests when we talk about ears and hearing. So we've got the EOAE, which is the Evoked Autoacoustic Emission, and it's a newborn screen. Can I move this up just a little? There we go. In the corner of my screen. There we go. And this ear emits, it emits sound when given a stimulus. And this shows that the hair cells of the cochlear are functioning properly. So then we've got the ABR. We used to call it the BEAR, but it's the auditory brainstem response. And it is another newborn screening tool, and it measures sound-induced electrical signals in the cochlea. Those of you who work in L&D or in nursery, I'm not sure any of you work in nursery, but those of you who work in L&D have probably been around the ABR. This is what we use here locally in our nursery. Excuse me. No, I don't have COVID. I'm just dry. Excuse me for a second. So the ABR is pretty standard, and we're going to talk more about the newborn screening test in a little bit, and how that came about. Audiometry is another test. This is pure tone hearing. We start trying this at age 3. We're not always successful because they're not always cooperative. We have, it's really interesting. We've been doing audiometry, handheld audiometer for years and years and years. When I was school nursing back in the 80s and 90s, we had the little machine that sat on the table, and you put the earphones on the kids. So you couldn't tell if they were hearing something or not. You just knew when you were pushing the button and it was supposed to say that, there was supposed to be a sound there. I like that because I could face the kid and do this. The handhelds are great because you're depending on them to respond. The problem with the handheld is there is a predictable distance between each sound at the different levels. So we test at 20 decibels, which is a whisper, and we test 500, 1,000, 2,000, and 4,000 hertz. Now, if they fail this, we refer to an audiologist. Actually, most of the time we check the ears really good. We have them come back, we do a repeat test. Then, unless it's just really bad or mom is complaining that they're having problems with hearing, or if they failed their hearing test at school and they fail it with us, then we send them straight on to audiology for further evaluation. But as we're going to talk about later, the criteria is that they have to fail at 40 decibels, okay, not 20. So, and if you've never done one of these, if you've got those when you get back to clinical, if you can have them do a audiometry test on you so you can experience what that is like and what the child is experiencing, because in a very busy office, as even in an exam room, if there's other siblings and mom can't seem to shut up most of the time, no offense to any of you all, I have no idea if this is you, but it just grates me. I'll see one of my staff trying to do a hearing test, or I'm doing a repeat hearing test, and mom will talk to me the whole time that I'm trying to do a hearing test on this child. It's like, hello, shut up, please. I don't say that. I would never say that to my wonderful parents. But it's just something you need to experience if you haven't done it so you can appreciate it better. Now, tympanometry is another type of test. This evaluates the function of the middle ear. And this assesses movement of the TM by applying pressure to the ear canal. So this is another handheld instrument. Again, if you have these in your office, in your pediatric office, get it out and use it. And we're going to talk more about the results. Tympanometry basically helps us to assess what the function of the TM is. Is it functioning like it's supposed to? Is there potentially still fluid behind the ear? So when you do this, you have to have, they've got different size heads that you fit on the tympanometer, and you have to have a really good seal. And with kids, you don't pull up and out like you do with adults, whether you're looking in the canal or whether you're doing a hearing test or a tympanometry. You've got to pull out and down to get the canal straight enough to be able to do these. And you can't be easy about it. You're going to have to pull down and out because you won't get the canal straight and you won't get a nice good fit. So what happens is when you hit the button, it starts doing a sucking motion. It feels like you're sucking your eardrum out. So if these kids have got fluid or if they've got an otitis media, this is very uncomfortable, very painful. They may start screaming. So be prepared if that's there. Oh, shoot. Okay, the next one is pneumatic otoscopy. And I should have brought my ossiflator with me today. I didn't even think about that. I've got it at home. If you've never seen an ossiflator, it's a little bulb attached to some tubing that fits into the side of your otoscope. So look at your otoscope. It should have a little hole in the side of it, and that's designed to put your ossiflator in. Now, this has kind of been the gold standard for diagnosing an otitis media. This also requires a really tight seal. Now, you can't get a really good seal with our regular ear tips, either the 2.5s or the 4.0s. You almost have to have the specialized earpieces like you use with tympanometry to actually get that tight seal. And what you're doing, and this is a real technique that you have to learn. So you're holding the ear down and out, and you've got the ossiflator along with the otoscope in your hand. So you're looking at your ear, and you have to be able to learn to look and squeeze at the same time, and it shoots air into the ear. And if and you just watch the tympanic membrane move. So if you can, I bet you all can probably find either a YouTube video or something that shows the use of pneumatic otoscopy and how it makes the eardrum move. And if you can find that, I think Dr. Blankenship's over here shaking her head. She's like, okay, I'm gonna look for that. So she may be able to find that and load that up for you. It's great, but if the kid's got fluid behind the ear or a perf or something else going on, they may come off the table when you shoot air into that ear because it can be very painful. So be very careful. And our last diagnostic test is tympanocentesis, and this is actually aspiration of the middle ear fluid. And this helps identify persistent infectious organisms. Now, this is rarely done, and this is the outside of your scope of practice as a primary care provider, unless you're working in an ENT office and they train you specifically how to do this. You're not going to be doing it because this means you've got to go in with a scalpel or with a needle and go through the tympanic membrane on a child and aspirate fluid on the other side, which usually it would be best if they were asleep because it's really hard to get a kid to be still, and no matter how well they're being held or tied down, this is really hard to do. So usually they need to be asleep. And a lot of times if there's persistent fluid, like when they put in ear tubes, they'll do a tympanocentesis at that time. Again, and then you get a culture and we'll see if we've been doing the right thing with them. All right, so moving forward. Now, this is your tympanograms. This is what you're gonna get printed out after you've done tympanometry. So you've got type A tympanograms, which actually type A regular is a normal tympanogram. And then it's got a really nice peak. That means the eardrum is functioning like it's supposed to. If you've got a type A, I can't see what that says. D, a little D. So you've got ossicular discontinuity or scaling. So it's normal, but we do have some issues. And then you've got a little bitty curve, and that's an AS. And that means at some point in time, there's been scarring of the tympanic membrane. And that can happen through PE tubes or perforation, or maybe some sclerosis of the eardrum due to recurrent ear infections. So if you've got a type A, be happy. Now, if you've got a type B, we call these the flat. These are flat. And that usually means we've got a couple of problems. It could be as simple as that you're occluded with wax because you can't get it to the tympanic membrane to actually test it. It could, most of the time it means we've got otitis media with fluid. Sometimes you've got it in wrong. Sometimes if you redo it, you might get it better. Of course, anytime that you've had trauma to the eardrum, then that can also, you're going to have flat tympanograms for the rest of their life. One of our patients with one of the docs that I work with was a kid that is a miracle that he is still alive. He, if any of you are from around here, he was a child that a couple of winters ago was on a sled behind the four-wheeler on his dad's, and they were playing around in the snow, and they turned a corner, and it threw the sled into a electrical pole. He had a TBI. It perforated both eardrums, did horrible stuff to the cochlear nerve and the bones. He has some mild hearing loss. He's a little bit behind in school. He still gets really tired sometimes, but the kid is amazing. His mom's a nurse practitioner, so it's really interesting to sit and talk with her about her experience with that. So trauma, head trauma, car accidents, those are things that you need to ask in your assessment if they've got problems with hearing. So type C tympanograms are going to come early in the cycle, because on your paper it's going to show you where it should peak, just like this does. And so yeah, you've got a peak, but it's early, so you've got some negative pressure going on. So it's either going to show you've got some eustachian tube dysfunction, and it could be, you could be really happy with a type C if this is post-otitis media that you've had trouble clearing up. At least if you're not flat anymore and you've got some, if you've got a type C tympanogram, you're happy. Also, weather plays a huge part in that. So I would say right now, most of us would have maybe a type C just because of this wonderful weather. All right, so hearing screening. Hearing screening is very important. We talked about that we're doing it at the newborn level. Some of you may say, well, we've always been doing that. No, we haven't always been doing hearing screening. Several organizations starting in 1907 started advocating for early hearing detection, or detection of early hearing loss, and prior to 1 month of age. So they started doing it in the nursery, and those are your EAOE and your ABAR, or the ABR, and those are common. And so anytime we have an abnormal hearing test, the hospital and the state lets us know, because all of those test results are sent into the state. And so it's our responsibility as primary care providers to make sure that these kids have had a follow-up by 3 months of age. And we usually do that through one of two venues. We either get them into audiology with one of the ENTs in town, or we get them to the Commission for Children with Special Health Care Needs. Unfortunately, this is not bias on my part, it just is what it is, in that a lot of our Medicaid patients end up going to the Commission, but they are absolutely amazing. So they do a very thorough exam, and they are right on top of the follow-up. So if it is abnormal again, then they usually have started intervention by 6 months of age, which, as we all know, early intervention equals better outcomes. So, and those are our two tests that we talked about. I will tell you a little side story. We had there was a Amish family that tried a home delivery, and she was not progressing and ended up being brought in, and she had a C-section, and the baby was very large for gestational age, and they refused the hearing test. They refused hepatitis B. They refused everything that they could refuse and still get out of the hospital. But it's really funny. We got a letter saying that they had failed their hearing test. And so I was like, wait a minute. So I had to go back and get the hospital record and make sure that they hadn't failed their hearing test. But they hadn't. So I guess no result is reported as a fail to the state. So be wary if you get a failed and you happen to have a family that you know, like this Amish family, that did not get the test done. Just verify things before you assume that they actually had a failed hearing test. Okay, so that's that sidebar note. Now, as we talked in the very first class, the American Academy of Pediatrics, as well as all of our through Bright Futures, and now most of our insurance companies are requiring, especially with our well child checks, we start pure tone audiometry at 3, this says 3 through 6, 8, 10, 12, 15, and 18. Now, in our particular office, we do it 8, or we do it 3 if we can, as soon as they're able to actually do it. And then we do it from that point through 11, and then only after the age 11 if they are having issues or if they've had to fail test at school. Now, in trying to, I can't get my staff to understand that these new regs that we are getting, that we're required to do, say there has to be a hearing assessment after the age of 14. So when we do that 16-year-old checkup, because they've got to have shots then, which are required by school, so they've got to come in. That would be the perfect time to do that hearing test. So I just can't get them to do that yet, but if we get knocked on it, they may start doing it. I guess we're going to have to lose money on it before they'll start doing it. But one of the things that I do as a provider is when it goes to my diagnostic test, and we've got the Snellen stuff because we still continue to do Snellen through whenever they leave our practice and move on for their well child checks. So we do an eye screen. So I always address denies any issues with hearing, so that at least lets the insurance provider know that I've assessed hearing. So I don't know if it's going to work or not, but that's what I'm doing. And back to what I was going to tell you earlier, we have 2 machines in our department. The old audiometer that you hit the button and the tones go up, and they're at a frequent interval. And then we have a new one, a new handheld audiometer that I absolutely love. The patient doesn't have to interact whatsoever. I guess it's more based on the ABEAR than anything. You just do it and start it, and it tells you whether they pass or fail. And I'm loving it, because then you don't have to depend on the patient to answer when they've heard it or not. So I wish we'd get 2 more in the department, then we wouldn't have to fool with the old one, but we'll see. But I like the new one. So I don't know what you've got in your office. Check it out if you haven't already, whenever you get back to clinical. All right. Hearing loss, as we talked about earlier, is defined as bilateral pure tone hearing loss of 40 decibels, okay, or more at frequencies of 500, 1,000, and 2,000. And as a school nurse, those were the frequencies that I tested. I sometimes tested 4,000, but if I had hearing loss, if they were over 40 in a school, it was really hard to get a really quiet place to do hearing tests. So, but it was my job to test, and if I retested and they failed again, and then I referred them. That was my job. On this side of it, as a provider, it's my job to do it again and then check the canals and see if there's anything else going on. I didn't have otoscope back when I was school nursing. I think they do now. It's a different kind of world. But we got 3 types of hearing loss. We've got sensorineural neural, which is damage to the cochlea, and that can occur from birth or before birth on. You've got conductive, and it's either congenital or acquired. It implies problems in the middle or the outer ear, okay? And then you can have a mix. And we've got lots of kids that will have some conductive hearing loss, and those can be due to lots of things. Anytime with the sensorineural, anytime that you've got any kid with facial cranial anomalies or low ear set, ear anomalies, tags, or Treacher-Collins syndrome is another one of those. It's a weird congenital syndrome. I've had one kid in my practice in Eastern Kentucky, and it's called fox face, and he was born without any ear lobes. So he's got cochlear implants. And so hearing, of course, that's sensorineural. We get congenital a lot, of course, with recurrent ears or any trauma to the ear. And as far as hearing loss, you really don't make that diagnosis. That's not in your repertoire. You can say that they have failed a hearing test or that they're having difficulties with hearing. There's all kinds of ICD-10 codes for that. But it's your responsibility to refer to ENT or audiology, and then for follow-up of any failed screen. So one of the things that we talk about that can cause a failed hearing screen is cerumen. And I have kids with cerumen a lot. And removing cerumen can impact your hearing test as well as other things. And if you've got a kid complaining with that pain in their ear, and you look in that ear and you can't see anything due to this wax, you've got one of two things. You got to get it out, or you're going to ignore it. But you can't ignore it because that's why they're there. They've got pain in their ears. So there's a couple of different ways. And if you've ever taken a curette and tried to get wax out of an ear, adults are usually easier because number one, they've got bigger external auditory canals, or two, they also will sit most of the time much better and be still while you're cleaning it out. So, but we still have wonderful little curettes. Some of them are metal, which a lot of offices use. They have a little loop on them. And you can sterilize those, reuse them, or they have plastic. The plastic ones are nice and bendable, and it's a one-time use. And there's different styles of those. I like those better. If the kid if known to have PE tubes, do not try to clean out the ears. Okay? I don't think I said that. Do not clean out the ears. That wax may be attached to that tube, and if that tube is in place, then you can pull it out of the eardrum. Okay, so if the kid is nothing more than your otoscope needs to be in that ear if a kid has PE tubes, unless you're doing, and we're going to talk about something else later, unless you're doing a swab. So we can take it out mechanically. Older kids are better at doing that than younger kids. It depends on the child. Some 18-year-olds I have had that it's like, really, you need to grow up just a little bit. But anyway, most of the time, 99.9% of the time, we use gentle irrigation. And that is, we're using water, either a syringe, a water pick, or one of those big bulb syringes. So in different practices, I've done different things. One provider I worked for had one of those 50 cc syringes, and he had taken a IV catheter and taken, of course, the needle part of it, and attached it onto the end of the syringe because it was flexible, and he would use that to flush ears. In the office that I'm working in now, and this is what we've done even 25 years ago when I was the RN there, we use a water pick, and water picks are very good because you can start with very gentle pressure and it's consistent, and you've got like 800 milliliters from the start in the container, which is really great. And you want to start with gentle pressure because if you're taking a syringe and you're squishing and you're doing it fast, you can cause a lot of pain, and you can cause quite a bit of problem. A lot of times we'll mix our warm water, and you don't use cold water because you'll send the kid into absolute hysterics, as well as you don't want too warm water. So that old adage, if you're older like I am, we used to test when we heated up milk, our infant milk, we used to take it out and we used to shake it up just a little bit and then dab it on the back of our wrist to see if it was too hot or still not warm enough. So I still use the back of my wrist when I'm checking water temperature coming out of the faucet before I fill up my container. And I always check it first. And you always need to run a little bit through your water pick because the water that's in the line is going to be cold. So you need to run that warmer water through and make sure that your equipment is working correctly prior to actually starting with the ear. So, and start really slow, assessing the patient to make sure that they are comfortable. And because when you start shooting water in the ear, it can make some of these kids nauseated, and it can also cause some vertigo. So you need to be really careful about how you start. But I always mix some hydrogen peroxide. And it's one of our common ceruminolytics that you can use. So I will mix a lot of peroxide in with my water. Now, you don't want to tell patients or parents to put peroxide in their ear if they're a big waxer all the time, because as we know, that peroxide can break down the skin tissue. So if we use a lot frequently, or even some frequently, you can cause some issues with the eardrum or in the ear canal as far as irritation. But usually it gets it. The interesting part about using irrigation is it is a billable. I guess I really shouldn't talk about billable things, but I guess they need to know it. This is a billable procedure. And insurance companies are only going to pay for an MD, MP, or a PA to do it. So there's a lot of times I'll be seeing my patients and they'll come get me and say, you need to come flush an ear. It's like, okay, give me a minute, get everything set up and I'll be there. Because if one of our staff do it, then it's not considered billable. So anyway, it is what it is. Some things that you can give, ideas that you can give parents as far as things to put in the ear to help break down the wax so it comes out easier is Ducosate sodium or Colace. You can put a pin in the end of a Colace and squirt that in there. Mineral oil, olive oil, baking soda mixed with water. I've never done that. I can just see frothing coming out of the ear and a parent going absolutely berserko. Again, peroxide is another one. Now the oils there, they will soften the wax, whereas a water-based will disintegrate the wax. So there's also Debrox, which you can now buy over the counter. And there's Neil Med, N-E-I-L. I just know that they make this. It's over the counter stuff that you can shoot in the ear to help decrease cerumen. I have a 27-year-old that still has problems, and he'll come home every once in a while and say, Mom, he doesn't live here. So when he comes in, he says, Mom, I need you to clean out my ears. So I had this little handheld thing that I bought over the counter that I fill up with water. It doesn't, not a whole lot of water, but it has a little push button, and the tip is curved. And so I will fill it up with peroxide and water, and we'll flush his ears until the wax comes out. He always lets me know so I can take my otoscope home so I can make sure that I've got his ears cleaned out. So, but cerumen is a big deal. A lot of times parents will clean, so we have to teach them not to use a Q-tip in that ear. The old adage that my ENT, back when I was a little girl, Dr. W.G. Begley, told my mother is that you don't put anything bigger than your elbow in your ear or your child's ear. So, not bigger, anything smaller than your elbow, sorry. You don't want anything smaller than your elbow, which means don't put anything in the ear. So you can clean the outside with a Q-tip. You can clean what you see, but don't go digging. And I get so many parents that come in and say, oh, I'm so sorry, we didn't clean ears today. It's like, that's okay. You're not supposed to. Leave that to me. That wax has a purpose. And the only person that needs it out is somebody like me if he's complaining with, or that patient's complaining with an ear issue. So because cerumen is very important in the protection of the ear, okay? All right. So let's talk about some different ear conditions. The first one we're going to talk about is an external auditory canal condition called otitis externa, otherwise known as swimmer's ear. There are other things besides getting in the pool that will cause otitis externa, but a lot of times it really, really relates to water, as we'll see as we go along. So the definition of this is inflammation of the external auditory canal. So you're going to have edema in the ear canal. You're going to have a diminished diameter of the canal. Sometimes you're going to have pus. Sometimes it's going to be like this. It's like, okay, you can't see through that canal. Sometimes you can't, it's so swollen that you can't see the membrane. Sometimes it's going to have pus or a flaky white stuff. Sometimes it's going to be really red. But I'm going to tell you, if you touch that ear to pull down and out and that kid cringes, that's the first sign that you've got an external auditory canal infection or an otitis externa. A lot of times too, if you push in the mastoid area or the tragus, push in the front of the ear, and they have pain, then your differential the first differential should be otitis externa. So now, usually this is due to a breakdown in the waterproof barrier of the canal, and it's usually from retained moisture. So i.e. swimming in the summertime is very good. We see this a lot because the pH of the ear canal is very acidic, and we want that acidic environment. okay, because that prevents the growth of microorganisms. So anything that's going to actually increase the pH, moving it from an acidic environment to a more neutral environment, will cause an otitis externa. Pool water is alkalinic, so it's very basic. So it pushes the pH of that ear more toward neutral. So also, how does a kid get a otitis externa in the winter if they're not going to the pool? Well, interesting part of that is we've got a lot of kids that like to play in the bathtub. Playing in the bathtub is not bad. They also like to put their heads down in the water and let their ears, just where their faces are up, so their ears are underneath the water, and they're laid like this. And they'll lay like this, and they'll do it like every night or so. And maybe mom and dad are in there. Maybe they're not. Maybe they don't know that the ears have been under the water for an extended period of time. But if you do that persistently enough, it's going to push that pH with that chlorinated bath water more toward neutral. So the treatment for this is antibiotic ear drops. And there's only 3 eardrop types that are not ototoxic. Not ototoxic, and that's really important. So you've got Ciprodex, which is branded, but that is ciprofloxacin and dexamethasone together. Now this can be really expensive. You can always tell your patients that there is a coupon on ciprodex.com that they can go and get and take with them. Another type of eardrop is called floxacin or ofloxacin. And most of your Medicaid patients it's going to pay for this. So I very rarely, unless I've got an insurance patient that I know that can pay the copay with this, I very rarely anymore, unfortunately, use Ciprodex or ciprofloxacin with dexamethasone as far as generic, because ofloxacin is covered on most insurances or all insurances as well as your Medicaid. And most of the time I see mostly Medicaid. So the other one that is acceptable is, and the brand name is Vasocidin or cefacetamide, and it's got prednisone in it. So now the interesting thing is everybody wants to use tobramycin or Tobradex, and if it's got neomycin in it, we don't need to use it because neomycin can be ototoxic, and you don't know if you've got a perf or not sometimes, but you really don't need to use those. Kind of get them out of your repertoire, especially with kids, okay? Also, your literature in your book says that with an otitis externa, you really don't need hydrocortisone in the ear. So think about that too, because some of these generics are mixed with hydrocortisone. So you may see ciprofloxacin and dexamethasone, but you also may see ciprofloxacin or ofloxacin and hydrocortisone. Be really careful about that, okay? So no hydrocortisone in the ear canal, at least for swimmer's ear. So that leads us into another type of thing that we have to deal with in pediatrics when we talk about things in the external auditory canal, and that would be foreign bodies. Kids will stick anything and everything in any orifice they've got. Any orifice they've got. And we're going to talk about that, how that relates to GU next time when we get to GU. So it's really common that you get kids that put stuff in the ears and you never know what they're going to find. Back a very long time ago in Harrison County, Cynthiana area, I was working a Friday and Saturday nights, 3 to 11 there. Don't ask me why that weird. That's a long story. But I was the extra nurse on the 3 to 11 shift on Friday nights. So I frequently found myself in the ER, and it wasn't your typical like big ER. It was just a little community ER. So there was a kid that came in one night and there was green growing out of his ear. Mom was absolutely, what the heck's going on? Well, he had stuck a bean in his ear, and it was a warm, wet environment to the point that bean sprouted. So it just lets me know how frequently that mother was cleaning that child's and checking that child's ears. But anyway, we have seen beads and toys, bugs, roaches and ants and other bugs. ladybugs, beetles, anything and everything I've seen in ears. If you can get it out and do it. I mean, if you think you can get it and get it out and the kid's going to be still enough, do it. You've got to have cooperation and you've got to have the right equipment. It's important to get it all out. It's really important that you get it the first time. If you don't get it the first time, tolerance dwindles and you have less chance for success for removal with each new attempt. So if any of you have ever worked with the CATZ extractors, K-A-T-Z, those are really good. It's this little thin little tube, and on the end of it has a balloon that you can blow up when you insert. If you can get it past the object, it'll slide around the object, and then you inflate the bulb behind and gently pull it out. Those are great. Alligator forceps, really thin forceps are also good. But again, if you can't get it, or if you get part of it, or the kid's screaming and not moving, it's best then to refer that on to ENT, where they have the better equipment to get that out, where they can watch it as they get it out, because you can't watch it. You don't have the right kind of equipment, most of you in your offices, to be able to watch while you're doing that. So, foreign bodies, they're so much fun. Always stories to tell. All right, so let's talk about 90% of what we see in pediatrics when it comes to ears, and that is acute otitis media. On the left-hand side, you've got a normal looking TM. You see it's a pearly gray, translucent. You've got a cone of light at about position 7 or 8 o'clock. I'd like to see this cone of light bigger, but again, this is a picture versus me actually looking in the ear. You can see the bones of the malleus behind. It's not particularly prominent. And you can see the enough of the canal to know that it's not inflamed. So on the right-hand side, you have a red bulging TM. And in about between 2 and 4 o'clock position, there you also see a yellow pus behind that eardrum. This kid is in a lot of pain. You also see redness of the canal too, around that eardrum. This kid's probably in a lot of pain, maybe even running a fever. So, when to call it otitis media. And so while I'm doing this, want you to look, uh-oh, I didn't mean to do that. Dr. Blankenship, how do I get back down and get my article up? Do I have to go out of I have to escape? There we go. I'm getting it. I got it. Okay, so on your screen now should be the article from the American Academy of Pediatrics on the diagnosis and management of acute otitis media. Now, this was revised in 2014 from the 04 guideline, as well as in 2019, I've checked and it has been reaffirmed. So this is still the gold standard by which to diagnose and treat otitis media. This is a very thick, long guideline. It's huge. It's really thick. But the most prominent parts of it are the first couple of pages past your abstract, actually the first 2 pages, because it talks about your key actions. And if you want to read further, then please do, about each key action and symptoms. And as you get more into, on page E982, it starts talking about susceptibility to antibiotics, and we're going to talk more about that in a minute. So just read this if you want to print it out. And is that, nope, that's not it. Bear with me for a second. Where's my other? Nope.
Go back to Firefox. I think it
did. And it says, please click OK if you see the dialogue item.
Oh, no. Hold on.
Is it this one right here? There it is. Okay. Now this is a widescreen for me, but on your computer, oh, looky there, it's a touch screen. All right, this is at the bottom of page E983. So hold on to that. What I did was I took this and I blew it up big, and it is at the bottom. It's in that article, so you would have it separately. So, whoops, I want to go back to my PowerPoint, and we want to go back to, there is, no, go away. I want to go back. I'm learning as we go, guys. So, nope, that's not what I wanted. Nope, that's not what I wanted. Nope, there's my PowerPoint. And I want it to go, I want to go to back to my screen, big screen. Slideshow, there we go. Slideshow. And, oh, no. Okay, from current slide. There we go. Okay, I'm back on. Yay, me. Okay, so when do we call it otitis media? If they present, according to your guideline, with a moderate to severely bulging of the TM or a new onset otorrhea, not related to otitis externa. And you may see a lot of that. I've seen blood, pus, white, serous. So there's a lot of things that come running out of the ear. Also, number 2 is if it's present with a mild bulging and recent onset of ear pain or intense erythema of the TM. So you can have a really red TM, and if the kid's complaining of ear pain, then you can call it an otitis media. The interesting part, if you've got those small babies and kids who can't say my ear is hurting. So what are some of the signs that you're going to see? You're going to see babies that are fussy and irritable, that when you lay them down, they start crying. When you pick them up, they're more consolable, because what happens is when you lay them down, it puts pressure on that eardrum and they start screaming. It's very painful. They may also have a fever, and they don't want to eat. Babies, if they're especially nursing, has become harder. Anytime you have that sucking action, either nursing at the breast or on a bottle, it puts pressure on the eardrum. So they don't want to eat. And then they get hungry, and then they're mad because they're hungry, and they're mad because their ear hurts. And a lot of times we get the parent in the office and they're absolutely on their last nerve, they don't know what else to do. They're exhausted. And then the other reason that we would call it an acute otitis media is if they have middle ear effusion, and that's based on your pneumatic otoscopy or your tympanograms. And a lot of times we'll have a ear infection, but they keep the fluid, and no matter what we do, the fluid persists. So it's going to be really important for you to assess for pain and treat as needed. Aralgan drops don't always work, and if there is a question as to whether there's a PE tube or whether they've had a perf, you're not going to use those types of drops, okay? So you're going to treat it with oral antibiotics. We're going to treat all severe bilateral or unilateral or either non-severe bilateral with antibiotic. So in the wonderful Ohio Valley region, with all the allergies and all the other stuff we have frequent kids with ear infections. This time of year, it's been bad. Also, ear infections go along with some of our viral processes, and that's a whole nother ball of wax. They get a cold, and it goes to the ears. So they've had a URI, now they've got ear infection. And sometimes flu and ears are very common to see together. So sometimes if it's a subacute, maybe it's a little pink, maybe it's not red and bulging, they're not running a fever, maybe they've just recently been on antibiotics, it's very much approved to what we call watch and wait. So that's another treatment option. And I've done this several times recently with some kids that had just been on antibiotics. Mom wasn't really excited about putting them on antibiotics again. They've had recurrent ears. Is there a possibility that this could go clear up on its own? Yes, it is. So you can offer observation, watch and wait. Sometimes, like if it's on a Friday, I'll go ahead and send the antibiotic in and say, okay, if the symptoms get worse, or if you think they're not going to get any better, if they start running a fever, go ahead and fill this. And a lot of times it's like, okay, check with me before, if it's earlier in the week, I'll say, check with me within 48, 72 hours. Check with me before the end of the week if they're not getting better, and then we'll do something. I don't always make them come back in because that's just a lot of parents work. So you have to use your best judgment. You have to know your parents. That's another wonderful thing about primary care peds, is that you build a relationship with these parents and they trust you. And so if you stick to your word, then they're good about doing what you tell them to do. Okay, you work with them because it's all about compliance. So we have to make sure that the plan is going to work for the parent and the child. So, like I said, a couple of times recently, I've done the watch and wait, and the parents have come within a couple of days and said, we're getting worse. So I'll call in the antibiotic. I don't make them come back in. Again, that's your choice. But in my practice, like I said, the parents that I do that with, I can trust. So I feel comfortable. I've seen those ears. I already knew what they were looking like. I know what the situation is, and I feel comfortable prescribing an antibiotic, even though I just haven't seen them that particular day. But again, that is your license and your decision. So just beware. But know that that's an option. All right, moving on. So what are we going to treat these kids with? Now, according to your guidelines, they're going to say Augmentin is your drug of choice. Augmentin or amoxiclav is great medicine. The problem with that is it's not very palatable. And it can cause diarrhea and upset stomach on an empty stomach. So again, compliance is a huge issue. So your guidelines even talk about, and it gets down to amoxicillin, and this says 80 to 90 mg per kg per day in divided doses. Well, if it's a 6-month-old and this is his first ear infection, you're not going to start out at 80 to 90 mg per kg per day. Also on page E982, it also says you can start with 40 milligrams per kilo per day. And that most of the time, 83 to 87% of these ear infections are caused by a microorganism called Strep pneumoniae, and that's it. Strep pneumoniae and Haemophilus influenza are two of our biggest bacteria that cause ear infections. Now, the wonderful thing is we have vaccines against those two wonderful things that help reduce the overall problems with ears. And the other most common bacteria, we're going to talk about this, and I have trouble pronouncing this, is Moxarella catarrhalis, and that may not be how it's pronounced, but that's how I pronounce it. So forgive me for bad pronunciation. But your 80 to 90 mg per gig per day is your kids who have persistent or recurrent, or they've had 3 or 4 and it was a couple of months ago. Well, maybe we need to do, amox at 80 to 90 mg per gig per day. Now, what you need to remember as providers, because I've had some FNPs. I had an FNP student call me one night who had been my student, and she called me and says, hey, I've got this 70-pound kid, and when I figure this up, this is this dosage. And it's like, so what's your maximum daily dose for an adult? What would you give maximum to adult? And she told me, and I was like, and you're going to give more than that to a kid? Well, no. So know what your maximum doses are per 24 hours for these medicines, and don't go above it. So 80 to 90 mg per kg in 2 divided doses, that's a lot of medicine for a older kid. Okay, so think about that. Amoxicillin is our drug of choice if they're not allergic and if they have not been on it in the last 30 days. So if you follow a penicillin with a penicillin, then are you really, and it didn't do any good, or we're recurring already, then what are you doing? You're throwing money down the drain, and you're increasing the potential for antibiotic resistance in this kid. The other thing about if you use amoxicillin, they do not need a concurrent purulent conjunctivitis, because a lot of times ears and eyes go together. So if they've got the draining eyes, amoxicillin is not your drug of choice. Okay, we're going to use something else unless they're allergic. Okay, so amoxiclav or Augmentin is also a very, very good medicine for ears if they haven't had amox in the last 30 days. And this you can give if they have, and highly recommend that if they've got the draining green eyes, the goopy eyes, and tell mom or dad why you're choosing Augmentin over amoxicillin. And you also need to do some teaching with them. Okay, you're nurses, right? That's how you started. So as nurses, teaching is a huge part of what we do with our patients. You're going to get better compliance from your parents if they know why they're being told they're doing something. And why did you choose this over this when this tastes better and this sucks? Okay? And give them strategies. So Augmentin is going to can cause diarrhea, nausea, vomiting on an empty stomach. So tell them to feed those kids before they give it to them. But if they start having really bad diarrhea, call me, I will have to switch it. So they've got an out, but they're going to try this medicine. Okay. So that's with amoxiclav. Now, the other interesting thing is if they are penicillin allergic, you can't use either one of those two. So we're going to use a third generation cephalosporin called Ceftonir for a lot of reasons. Now, your thing's going to list several different other types of the cephalosporins, but Ceftonir is one of our drugs of choice for several reasons. Number one, it tastes good. Number two, if they're penicillin allergic, the likelihood that they're going to be allergic to a third generation cephalosporin is very minimal. I'm going to tell this story, and I'm not pleased to tell this story, but I got a walk-in note the other day from an NP that had treated a kid for ears that was allergic to penicillin with Keflex. And this kid had a reaction to the Keflex. Imagine that. Because it's a first generation cephalosporin, it is so much close to penicillin that the cross reactivity is almost guaranteed. So what did that NP do for this kid? Now that's made it so we've got a whole category of medicines that this kid can't take because they now have a reaction to Keflex. So you've got to have at least a second or third generation cephalosporin if you've got a penicillin allergic child. Okay? All right. So I'll get off my soapbox. But Ceftonir tastes good. It has a strawberry flavor. It can make their poop red. And you need to tell parents that because just tell them it's like, okay, it might cause a brick red poop. That is a normal side effect. Don't freak out thinking that they're bleeding from their bowels. And parents say, thank you, because I would have. Okay. And it's great also because it's 14 milligrams per kg per day. And you can either do it daily or you can do it twice a day. Now your maximum dose is 600 milligrams a day. That's it. That's all you can do in a day's time. So and that's 12.5 milliliters. I've done it enough. So, and it's because your suspension is 250 per 5. So 600 is 12.5 milliliters. That's the maximum that you can give in a 24-hour period. Or you can do, if they're old enough to swallow a pill, then you can do 300 milligrams twice a day. So now, for kids who are failed amoxicillin, failed Ceftonir, failed Augmentin, or we're back to back, we're right on top of each other, this kid, and we had this actually recently several times. You've got a kid who's been on amoxicillin or Augmentin, and now they've been on Ceftonir, and 4 or 5 days in, or even at the end of Ceftonir, they're back straight to having fever and ears, and they're red and bulging. So we'll do a ceftriaxone. Now, if you look at that paper at the bottom of E983, one of the alternatives along with ceftriaxone is to give a 3-day course of Clinda at 30 to 40 mg per kg per day in 3 divided doses. And this also says with or without a third generation cephalosporin. So you can add Clinda. We've had kids so bad we give them Rocephin shots, start on Ceftonir and a 3-day course of Clinda. Or if they finish their Ceftonir, they get the Rocephin and 3 days of Clinda. Or sometimes we'll even give them 3 days, 3 consecutive days of Rocephin shots. Now, Rocephin, if you've ever had one, burns, hurts, even mixed with 1% lidocaine. And in a child, you're not supposed to give more than 1 cc per injection site, but at 50 mgs per kg, if you've got a kid over 20 kilos, that's 44 pounds, they're going to get a whole gram. And that's your maximum daily dose is a gram. You don't go above it. Okay. That's 2.5 milliliters that they have to inject. So it has to be divided into 2 shots. It's bad enough to come at these kids, these bigger kids, with a shot, 1 shot, but you got to divide it up into 2. So they don't like you very much after that. And then they have to wait 20 minutes. And you have to tell parents that. It's like, okay, after this shot, they have to wait 20 minutes. So we make sure that we don't have a reaction. And you want those parents, they can't go to the parking lot, they can't go down the street and call you back. Because if they have a anaphylactic reaction to the Rocephin and they have left and you have not documented your 20 minutes, and you have to document your 20 minutes, then you're liable for any complications. So now, our kids that have recurrent, and the guidelines say that they have 3 episodes in 6 months or 4 episodes in a year, with the last episode being within the last 6 months, then they may need tubes. And PE tubes can be very scary for parents if they've never, because they have to put they consider it a surgery, and it is a surgery. They have to go to the hospital, their kids have to be put to sleep, and that's very scary. I experienced that. My youngest had tubes put in when he was 10 months old, and I was a working RN staff supervisor in my pediatric office, and it scared me to death. Now, my ENT and I had a really great relationship, and you know, he knew what I did for a living, so he allowed me to stay with my 10-month-old at the surgery suite until they got him to sleep. And before I could get downstairs, so they gassed him while he was in my arms, and they got him to sleep. They took him from me. I left, and before I could get all of my stuff, get downstairs to outpatient waiting, they were calling and saying that he was coming to recovery. So basically what they're doing is they get them asleep long enough so they're still, so they can go in, make that small slit, and put those tubes in. And then they bring them right out, and usually they're fine and dandy. They go right to eating, or they're ready to play. There's usually no post-surgical issues. They may have some drainage, especially if they had a lot of fluid behind their ears. Your doctor's going to give you, your ENT is going to give you as parents. So helping parents prep for this and make it less scary for them is really important. So what you're seeing in your slide right here is, on the right, you see a tympanic membrane that's got lots of air bubbles behind it. That is middle ear effusion, or serous otitis media, okay? That is serous otitis media. And sometimes the bubbles aren't that pronounced. Sometimes they'll just be little bitty. But that's when you see that, that is serous otitis media. There's not a whole lot you can do about it. Antibiotics are not going to necessarily touch that. Unless you got something else going on. Now, on the left-hand side, you see what we call a retracted eardrum with a yellow fluid behind it. So that's an otitis media. And what has happened is, if you've ever, we lived in a house for a while that had really bad windows back in early our marriage, and we used to have to put plastic over the windows in the winter to keep from freezing to death. And there was a shrink film, but we learned the very first year we couldn't shrink it down, because as the wind and the air pressure would come and go, sometimes that plastic over the window would be bulged into the room, and sometimes it would be sucked up next to the window. So that's what's happening here. There is so much goo in that middle ear that the eustachian tube is not working. So this is a eustachian tube dysfunction here, okay? And all that fluid is back there, and is basically sucked the eardrum up against the bones. So you're going to have some hearing issues and muffled hearing and pain. This is very painful. So how do we prevent otitis media? One of the recommended vaccinations is the pneumococcal conjugate vaccine. I know you've seen pictures, or actually ads on the TV, about getting your, especially for older adults, getting your Prevnar 13. That's what we give to kids. We give it at 2, 4, 6 months, and then a booster after their first birthday. And as we talked earlier, The three most common bacterial pathogens in acute otitis media is strep pneumonia E. Then there's non-typable Haemophilus influenza and that Moraxarella catarrhalis, and that I cannot pronounce and not going to try. Also, recommended flu vaccine. So a lot, as I said earlier, a lot of otitis media follows upper respiratory infection with all the drainage and the goo. It just goes straight up those horizontal eustachian tubes, because I don't think I said this time, because as children, babies have no neck, right? So their eustachian tubes are almost horizontal. So anything that sits in the back of the throat goes straight to the ears. So teething, bottle propping, feeding with laying down, any of that is going to sit in the back of the throat and go straight to the ears. Okay, and as we get older, eustachian tubes become much more vertical, thus we don't have as much problems with ear infections. So flu and all that drainage and goo that goes along with flu and colds causes a lot of otitis media. So we recommend that kids get their flu vaccine. The other part of this, and I think I said this the other day, I'm going to get on my soapbox for a minute. So we've had a lot of kids diagnosed with flu this season out at outside clinics besides with us. And instead of giving the kids Tamiflu, they have talked parents out of giving it. I had one kid that the dad said that he was recommended elderberry gummies for the flu. Now, I believe in complementary alternative medicines to augment health and to help with certain things and to help our immune system. But Tamiflu has been recommended by the AAP, which doesn't happen lightly, because it helps get them well faster and helps prevent flu complications, ears, pneumonia. We've seen a tremendous amount of post-flu pneumonia this season in kids. So if you've got a kid that you're seeing and they test positive for flu, offer the parents Tamiflu. Yes, not every kid can tolerate it. It can cause nausea and vomiting and the side effects. If you start listening to the side effects for every medication or vaccine, nobody would ever take anything anytime. But if these kids can tolerate Tamiflu, then give it to them. If the parent chooses not to give it to them, that is the parent choice. But as a provider, you need to do what's best for the child, for their health, and that is to provide them with Tamiflu. Now, the good news is, now you all probably all heard of Xofluza. Some of you may have taken it, which is a great new antiviral for flu that stops the replication of the virus. It's a one-time dose, and usually within 24 hours, you're feeling significantly better. Now, Xofluza has been for children 12 and older, weighing at least 40 kilos, which is about 88 pounds, okay? Next season, we've been told by the Xofluza rep that Xofluza will be in a liquid form, and we will be able to offer it for children ages 2 and above. And it's gonna be the same kind of thing, a one and done. And that's gonna be significant because the side effect profile on Xofluza is so much better than Tamiflu. But for right now, this is what we've got. And for your kids under 2, what are you going to do? You're going to offer them Tamiflu. Okay? So I'll get off my soapbox now. Okay. So lifestyle issues. What causes ear infections? What helps prevent ear infections? So we know that the literature says that breastfeeding for at least 4 to 6 months reduces your episodes of acute otitis media and recurrent otitis media. Does it keep kids from getting them? No, because we have a lot of moms that come in and it's like, but I've been breastfeeding exclusively. We're not supposed to have an ear infection. Well, things happen. Doesn't mean you won't get it, but it helps reduce the episodes. Bottles and pacifiers. And sometimes this is where it gets them. Bottles and pacifiers, because they're pumping and they're feeding breast milk via bottle. They've also been associated with AOM. Now, the interesting part is, with our new back to sleep guidelines, pacifiers are encouraged even in breastfeeding babies after they've established a good nursing regimen. okay? Because pacifiers have been known to help with preventing SIDS. Bottles, you know, we've got kids on formula, we've got kids who are drinking breast milk from the bottle. We just have to remember to teach our parents that they don't need to be laying flat. The kid does not need to be laying flat down when they're taking the bottle. They need to be up in that elevated position. And I tell the story that I am, that's personal experience, because when baby number 2 was born, I had a 3.5-year-old, and I was exhausted because my husband was still working and my mother was working. And so I was at home, and a lot of times at night, or even during the day, I was so tired, I would get that baby up out of the bassinet and I would lay down and nurse in a laying down position. And I did it a lot. Sometimes he fell asleep. I fell asleep. He fell asleep at the breast. That was not good for him. So he had his first ear infection at 2 weeks of age, and we had persistent ears until we had tubes at 10 months. So I learned that lesson from a parenting perspective before I knew important it was to keep that baby propped up when being fed. So we want to avoid that supine bottle feeding or bottle propping. We want to eliminate or reduce pacifier and bottle use after 6 months of age. We recommend start with a cup at 6 months of age. And parents will look at me and say, even with their formula? Or yes, like, yes. The quicker you get rid of that bottle, the better off you're going to be. Think about, you're not going to have to clean bottles anymore. Oh, well, that's true. It's like, yes, we want to get them to a cup. And when I start talking about that really reduces otitis media, then, you know, then that's another incentive for them to get them to the cup. And so we like to also get rid of that pacifier. We've got 2- and 3-year-olds who are still using the pacifier all day long, and their parents wonder why they're still having ear infections, or they've gotten tubes, and while we're still having ear infections on top of tubes. And you can talk sometimes very nicely till you're blue in the face, but they don't get, we got to get rid of the pacifier. Oh, but it helps them calm. It helps them go to sleep. Okay, well, as you see, the next one, pacifier use is associated with acute otitis media recurrence. So also your literature, both in your chapter and in this guideline, say that the use of xylitol, both lozenges and gum and syrup, especially during this time of season, is helpful in preventing otitis media. If they're little, you can't necessarily give them the gum, and the lozenges have shown to be more effective than the syrup. And I don't know if it's because they're chewing or sucking, and that helps clear out those eustachian tubes. I don't know. But if they're giving the syrup, they recommend it 3 to 5 times a day, along with the gum and the lozenges. But again, that's not something I have gotten, I have incorporated into my practice. But again, it's in the guideline. So if it's in the guideline, you can try it. And I'll be interested to see how, if you use it, then how it works for you. So some other ear conditions. What you see on the right-hand side of your page is you see your eardrum, and you can see at about 3 o'clock position the handle of the malleus, but you see almost like blisters on the eardrum. That whole eardrum is not bulging. That, and I've seen it with smaller blisters, but that is a bulbous laryngitis. It's very painful. You treat it like an ear infection, probably need to refer them to ENT. Now what you're seeing on the left-hand side is a congenital cholestoma. And this is a growth behind the eardrum in the middle ear area. Some of these are benign. Some of them have developed after trauma. And then some of them can be pathologic. So this is an ENT referral. It's not emergent, but it's something that you want to get. Unless you know the reason for why that has developed, it's already been looked at by ENT. On the right, you see a perf or a healing perf, actually. Usually if an ear has perfed, it's usually got something coming out, or unless it's due to trauma or other things. A lot of times kids, and my oldest, my 31-year-old, would never get an ear infection never show any signs or symptoms of anything until the middle of the night. He would come wake me up and say, Mama, my ear hurts. So we'd dampen a cloth and stick it in the microwave and get it warm. And I give him a couple of Tylenol and put it on his ear and send him back to bed, and he would relax. And a couple of different times, we would wake up with blood on the pillow where his eardrum had ruptured. Usually after an eardrum rupture, the pain goes away because it's the pressure on the back of the eardrum that's causing the pain. And perfs can happen. Perfs usually heal. Sometimes they don't. So if you see a perf, you need to, that's an opening directly into the middle ear. So you need to be really careful and tell them they need to be really careful. And if they know about the perf and their ENT is aware of it, then let them manage it, okay? So what you're seeing on the left-hand side of the page and this other one is scarring or tympanosclerosis. And that's usually either from a perf or from ear tubes. And a lot of times I'll look in the ear and say, oh, you've got some scarring on your eardrum. Or I'll just look in the ear and say, oh, you've had tubes. And they'll say, yeah, how did you know? I said, well, you've got scarring on your eardrum. So that's my way of getting history if I didn't know it before. So scarring can be normal. There's not a whole lot you can do about it, but be cognizant that this can cause significant scarring can cause conductive hearing loss. And so these kids need to be tested really well to make sure, followed up with ENT and audiology, that they don't have some hearing loss. And if they do, that is being followed up persistently. Okay, that is the end of otitis media. I'm going to let Dr. Blankenship come and stop us. And remember, if you've got any questions about this presentation or anything that you want to comment, send them to Dr. Blankenship, and we'll merge them all and post it on Blackboard. All right, guys, have a blessed day.
Back in a moment. You doing okay?
Yeah, I'm going to get my
Protein?
Yep.
It's right here.